Exactly. It's great to have you on today on this IGCS Regional Connect meeting. Thank you for joining us. My name is Christina Fotopoulou. I'm a gynae cancer surgeon in the UK, and I've been on the board of directors for IGCS since a couple of years. I now, in a few months, step out and will give the handover to Jo Morrison from the UK also. So we're very happy to have her. Our board and volunteer leaders are really dedicated to this, and we're very grateful to all their work. All this is voluntary work from all of us. We have tried to create a diverse community, a global community, and the team is showing you here the IGCS team. This is the 2026 board of directors. And we have a very big team of a dedicated staff without whom we couldn't really function and do anything. So Mary is the CEO, and it's amazing to work with her. And we have here Susan, Ashley, Paulina, who is here also on the call, Megan, Joel, Debbie from social media, you might know her, Rosie, Elizabeth, Mandy, and Shreya. So it's a nice, very nice, very well functioning team. Please, yeah, next slide. And I think I give over to Mary.
Thank you, Christina, and thanks everyone for joining us today. I want to welcome all of you to this membership initiative called Regional Connect. As IGCS continues to grow, nearly reaching close to 10,000 members, we think these regional connects are nice ways for each of you to kind of find your community, talk to your board representative, and as Christina said, kind of have this bi-directional conversation today. So we're gathering virtually. We believe that this interaction with your board representative is vital. We want to talk about things that are happening in the region, some challenges, and we also heard from some of you of some areas of interest. So I think, Christina, it's going to be a good webinar.
No, absolutely. Thank you very much. So indeed, this is just a platform for all of you and us to get inspired by each other. Many of you have already taken time to submit some questions, so thank you for that. And we are going to go through them at the end. So before we start this, some details on the IGCS membership. As Mary has said, IGCS has now almost 10,000 members. It was established really in 1987, so a few decades ago as a non-profit organization. Well, that speaks only for its ability to mentor, isn't it? And it includes not just gynae oncologists, but also radiation oncologists, medical oncologists, any clinician really who is dedicated to women's health. And yeah, so the mission is to enhance care worldwide. It is important to collaborate with national, international societies to promote research. All of you have been members in and also actively participating in projects in IGCS, so we are very grateful to you for that. Next slide, please. Here you see the members, the membership. The majority are actually from Asia, Oceania, and Pacific. And also the new president now of IGCS is Andreas Obermeier, who we are very happy to have from Australia, as you all know. So that is very good. And then next, please. Now, in terms of Europe, the largest representation is from the United Kingdom. I'm not sure now. I don't know if Joe is still on the call. I don't know whether theoretically UK is not anymore in the actual European area, even though if geographically it is, yeah. But we still count it as a European area. And then you see here the other countries that have been on. We have approximately 1,200 members from Europe, and also strategic partnerships. Next slide, please, with BGCS. This is the British Gynae Cancer Society, Ukrainian Society, and Belarusian Society. So, as I said before, it's very important to have these local allies and to have the collaboration. Next slide. Now, in terms of what the IGCS community will offer to its members, you can gain access to really a dynamic international professional community. You all know how IGCS has been working since decades, really. There is a comprehensive educational program which you can find online. Also, there are certificates that we can all do in terms of certification of programs, self-guided courses, so that you can really complete at your own pace. The access to International Journal of Gynae Cancer that is in collaboration with ESCO. There are engagement and leadership opportunities really within the IGCS in terms of mentoring, training, and I think this is really the most important of any society really, how we shape and we bring the new generation. In terms of connecting with each other, it's not really, we all live in an AI world, yeah. So there is special interest networks built within the IGCS community. There is here early career, medical oncology, pathology, radiation oncology, and all this connected through the different regions in the whole world, from Africa, Latin America. So it's really a global society. And no matter really where you come from, you will have the ability and the chance to interact with each other and get inspired by each other. Now, next slide, please. In terms of special interest networks, there is from IGCS and Early Career Professionals program, which is giving a bigger voice to the community and to the young, new, not necessarily young, but to the upcoming generation of gynae oncology so that they become the future leaders. And this is why there are very dedicated IGCS positions for early career president, president-elect, treasurer, secretary, treasurer, and the early career executive committee is playing a central role really in how to shape the future of the early career network. So it's something where young people, and I see also the names of some younger trainees are on the call. So it's great to have you all on board. Now, these newly elected leaders will help define priorities, guide strategy, because the world is really yours. The future is yours. So you might as well have a voice in how to shape it. Over the time, the vision is really for the network to include the development of dedicated committees led by these early career members and focus on areas that will include education, will include networking, advocacy, research. So this is really the focus. And we have, I think, at the end also some questions really specifically to that. This enhancement will be introduced in a phased and international manner, and the goal is really to build a foundation for sustainability. Now, very concrete examples. There is a surgical film library. I know that you have many that are online. This is one of the most comprehensive ones. More than 200 films are being reviewed by global surgical experts so that they really earn their slot in this library. This library is accessible anytime just by being a member. And you can do it from anywhere, really, from your laptop, from your iPhone. So it's actually very nice. And to this, there is also added a translated closed captions education 360 learning portal, which can be available in multiple languages. I mean, IGCS is global, so Spanish, Portuguese, Chinese, possibly. And being a global society, this is essential really so that you're comfortable in the language you're most comfortable with. Now, GTD, very important, and I work in a center with Mike Sekel, who is we are a GTD tertiary referral center. This is the GTD ECHO. It's a partnership with ISSTD and the ISGIP, the Society of Pathology. It's a tumor board, really. It's a monthly 1 hour virtual meeting to discuss GTN and GTD with global experts. And you can really take part, you can register for any of those. The next one is on June 25, so in 2 days. So you still have time to register. Then there is an expanded training programs. There is the steering committee lead here is Greta Dreyer from Africa, from South Africa. Nadim Aburusrum is the lead for the observership and research program. Mario Leitao for the MIS, so minimal invasive surgery. Raitan Ribeiro, he was from Brazil and now he's in Canada. For the surgical skills and short courses, and there is also a committee for cervical cancer surgery from Helen van Bekusen. So it's very multidisciplinary. It's largely very, very diverse. There is really a very high standard of and level of knowledge, skills to try to improve standards internationally, really. And yeah, everybody can be connected together. So this is one of the newest initiatives, and we're very, very proud to present it to you. This program is a bit shorter than a full fellowship, and it's designed to be a bit more accessible, more flexible, and a bit more affordable. So it's not like a big, 2 years course, but it's a bit more concrete. So I hope it will really appeal to you. Next slide. Now, ranging from short courses to observerships, there are many research opportunities really, and these programs will allow healthcare professionals to deepen their expertise. All these programs, their main aim is really to create connections. I mean, that's what we all try to do really, isn't it? At every level, no matter where we come from. And to support opportunities for further development inside any society, outside any society. But at the end, it's very important that we all connect with each other. And on that, I give the handover now to Mary to continue, please.
Thank you, Christina. Well, you've learned a lot about IGCS these last 18 months, right? It's amazing. So yes, I do want to touch a little bit on the research committee because they're starting to take shape in terms of some of their goals, and probably the largest initiative that they'll undertake will be this development of a rare tumor registry that will be global in nature. So we've got representation from all over the world helping to define the data element points, focusing on neuroendocrine, and I think the other one is clear cell ovary. So they're definitely getting themselves together. I think the other great thing about this is we will have central pathology review, meaning that each case before it's fully entered into the REDCap system will have some type of pathology review to confirm diagnosis. There's a ton of other rare tumors that we'll work on, but the board has kind of prioritized those two. So I'm grateful to Jubilee Brown for her willingness to share her expertise along with many of the others, involved in this. So it's going to be great. The other thing that you can do as a member is submit a research question that then can be asked of the IGCS membership. So we have a work group under the research committee. We get a lot of inquiries about surveys. So there's a form to complete. It's all on the website. And I would encourage many of you, if you have a research question you want to ask, IGCS's global community is a great place to do that. Super excited about Montreal. It's really a great destination for IGCS. It has so much to offer. We'll be there October 1 to 3. There's lots of great things happening in advance of the conference. So I would definitely go to the website, igcsmeeting.com, and you'll see all of the information about Montreal. I know Dr. Dreyer is very grateful to Paul Cohen and Anna Oakman and the entire scientific committee who just met recently in Chicago to look at the abstracts and to allocate some of those important slots in the plenary with those oral papers. So if you submitted an abstract, check your mail. You should have gotten a notification by now of the status of your submission. The full program is available, and early registration does end June 30th. So I'm sure Rosie's been busy fielding questions. I've had a few come my way as well. So June 30 will be here before we know it. It's always fun being a global organization to take our meeting around the world. So we're excited to announce 2027 and a partnership with the Japanese Society in Tokyo. That meeting will be held in early November. And then in 2028, we're now scouting out some Latin American sites. We've had some great proposals submitted to us, And we'll start that site visit with hopefully a decision made in October at the board meeting. So super fun to have a global meeting and take it around the world and really meet all of our members and friends of IGCS. I did want to touch on before we get to the member questions, Christina, is this World of Hope, global fundraising kind of development philanthropic effort within IGCS. We don't really have a foundation, if you will, but this arm of IGCS functions that way. It helps raise funds to support all of our initiatives, including our mentoring and training, getting education to some of the low middle resource settings, focused on cervical cancer, and now most recently on expanded training. So we hope that people will take a look at our World of Hope, our efforts that we're doing. And if you're in a position to help with that, we would really appreciate that donation. So Christina, I'm going to let you talk about June and Uterine Cancer Awareness Month.
Yeah, which is June. All of you know it means Uterine Cancer Awareness Month. This is a global campaign initiated in 2023, really. And you might see how everybody's jumping on Instagram. And it's really fun, actually.
It is.
And it's supported by the IGCAN, so it's the advocacy network and partners. So as we are moving into this Uterine Awareness Month, I wanted to highlight the Jump for June challenge. Yeah, so you can jump wherever, anywhere you want. And you can send a picture, which can go online alongside with a personal awareness message. This is something to get across not just to other professionals, but to our patients, to our community. So it's actually a very nice initiative. There is still time. It's 23rd of June today, so you still have a week to go if you want to, and you can check already on social media how others have done it. Yeah, it's actually really nice. Now, next slide. Very, very important engagement opportunities for IGCS members. This is here some pictures where you see people from all over the world, really. You can find a way to connect. And what are those ways to help and to connect is you can become a mentor or support colleagues in low resource countries. Yeah, low resource countries. You can join the virtual echo tumor board. As I've said before, this is a very, very exciting opportunity that was developed in the last years. It's very, very well perceived, and also people really seek advice for patients and for very tricky cases, and they're being addressed and reviewed by experts. Develop educational content within the IGCS education work groups, and of course you can be a peer reviewer in the IGCS journal, which I'm sure many of you are anyway doing. So for anyone interested, you can just scan the QR code. It's there, and also the team can send it to you extra if you wanted. So it's really very yeah, it's very easy. It's very straightforward. The IGCS team, the officers are very, very responsive. You can email, and you can also directly email them, and they can reply, engage with you, and to clarify any questions. So it's actually very easy if you wanted to be on board. Mary, are we going to the open forum?
Yeah, so this is, we asked for your input, and that is one of the beauties of the way in which I know it's sometimes annoying to have to register, but part of that process is it allows you to submit things to us. So Christina and I took the liberty of kind of clumping things together where we saw things that were submitted. So these were kind of the large categories. Of course, there's a miscellaneous as well, but I think we could kind of tackle some of these, Christina. I think, training, for instance, right? I think there are challenges in your region with training. I think, gynecologic training in general is always challenging. Certificates, certification, credentialing, lots of ways that people look at training and are seeking, I think, additional training. I think our expanded training offers more than just the traditional training, right? If you want more MIS, if you want to do our cadaver course, if you want to do an observership and be matched with somebody to go spend 2 or 3 months finding a mentor. So I think we offer a fair amount for all regions of the world. I know Dr. Abu Rustam has some thoughts on increasing some surgical presence in the next couple of years when he takes over. So I don't know, Christine, if there's anything specific on training that you would have related to Europe.
Well, it's not just related to Europe, it's everywhere really. Training is an issue, and especially since most countries don't have an accredited training program or even a subspecialty training category. No, I mean there are many countries that where gyne-oncologists are not really certified gyne-oncologists by through the country, but they're just focused on gyne-onc. So that is why it's very important to have international societies to be able to accredit them through that, and that is why it's important all this networking.
Yeah.
Now, in terms of legal issues, what matters is in each country the regulation. For example, in the UK, it's one of the very few countries where we have a centralized cancer care system. So you really need to be certified subspecialty gyne-oncologist to be able to treat cancer. So it's actually very, very, very easy and very, very nice, but it's not everywhere like that. And we all internationally really work towards a more standardization, homogenization of care now, because
And that's fairly new for you all, isn't it, Christina? That requirement?
for the UK,
Yeah.
no, the UK since ages, since many years,
But to
centralized.
be operated on by a GYN oncologist.
No,
No?
no, since ages. It's actually the
Oh,
first
good.
country.
That's
The
amazing.
newest countries are the Scandinavian countries. Now, Germany will start doing it, so that is more new to them. But the UK, it's at least since 20 years.
Oh, that's amazing. Yeah, that's great. And I hope maybe it will catch on a little bit as well. In terms of like collaborating and networking, of course, there's lots of ways to do that. If you're an early career member or considering it, this will be a big part of what they will do. They're focusing now on pragmatic trials. And as Christina mentioned, there's a webinar coming up here in a couple of days with our early career about asking the experts at the GCIG about establishing and setting up a pragmatic trial. We have funding for that this year, so we're super excited about that. Also, I think our research, or the new initiatives within our research committee will certainly create a platform for collaborating, whether it's between centers in these rare tumors or looking at the data aggregate, globally. So I think there's a lot of ways to do that. I don't know, Christina, if you have anything on advancing, and including underserved or underrepresented women in clinical research.
Wow, that's a very big topic. Do we have any questions for anybody? Anybody? I see something on the chat.
Oh, Joe has to leave, but Joe said since
Guidelines was
1999.
published in
Yeah.
99. I knew Joe would have the answer. It was published in 99 in UK.
It's
And that was
amazing.
so 20 years, no? Isn't it? No, it's
Yeah,
27 years. It's more than 20 years. Exactly. So it's 27 years. It's actually the first country.
it's amazing.
Yeah, no, that was very good. In terms of underrepresentation, I mean that's always a challenge. I don't know if
Mhm.
somebody who is on the call wants to say something. We all have experience really with those patients. I see also, yeah, many of you are treating, and many of you who are on this call, I know, and I know that we have talked and about the challenges. The only thing I can say and what I try to put in my clinical practice to just try to include everybody without any bias, without any, yeah, to be as inclusive as possible. And if at the end, yeah, they say no, at least we have offered everybody the same opportunity.
Right. Yeah, if anyone wants to share anything that's worked for them, I totally agree. And sometimes the inclusion and exclusion criteria can be hard as well in some of these trials. So I think the more we can work together with those developing the trials to make it as inclusive as possible.
Yeah, whereas now we are trying to be so much more inclusive. I mean, I remember
Mhm.
all the surgical trials, for example, the Lion trial. This was the surgical study 1,000 years ago.
Mm.
We had an upper limit of 75 years of age, 75, imagine.
Wow.
And now we have like no upper limit. For example, the trust study has no upper limit.
Yeah,
Um, I mean, yeah.
that's amazing. Yeah, I think there needs to be more consideration given to that, definitely.
Yeah, no,
Good. I know there was something about GTN, GTD. I think Christina referenced the Echo Tumor Board we now do with the ISSTD, who in fact is a great resource for anything GTN, GTD. They've got, their centers of excellence. They do a lot of work, obviously, in this area. And we were super excited to bring pathology along as well. I think one of the things submitted was, could we get a certificate? So I can bring that back to my team, but also to ISSTD and to the pathology organization to see their comfort level. We kind of get that from time to time, that if I sat in on an echo tumor board, which is an education offering, could I get some sort of, proof of attendance? So we'll definitely take that into account when we look at
Mhm,
further.
No, absolutely. That's
And then molecular markers. We wouldn't have we wouldn't have a webinar without a question about molecular markers, right?
Yeah, no, absolutely. So I can already, so what was the question about testing in gyne pathology and inclusion of molecular markers? So I can already disclose you to everybody that we are sitting again in the FIGO Endometrial Cancer Committee
Yes.
to update the 2023 FIGO staging just because of listening to you about all the issues with the molecular markers, etc. So we have now really a very dedicated molecular marker working group in this new figure staging that I hope will come out by the end of 2027 in order to try to, to improve that. What FIGO tried to do when we actually included in the endometrial cancer staging the molecular markers, which were not obligatory, if you already
Mm.
remember, they were optional, was to try to give an incentive to all commissioners and all stakeholders of every country to release money and to release resources to do that. Because now they could say, hey, listen, we need, as per the guidelines and as per FIGO, to have this molecular testing. So please give
Mhm.
us resources. That was the rationale. Now it backfired a bit because many people perceive that as a challenge. Why do we, discriminate potentially countries that cannot do that? It was actually the other way around. We actually did it extra so that we can increase options for also the low resource countries. I mean, what is low resource? We have to also say there are some countries who are very developed and still are not doing
Mm.
molecular testing. Yeah, we also have to be very honest about that. And at the end, we're spending all of us so much money for, I don't know, for immunotherapy or Pembro or PARPs, and we don't do the basic molecular testing. So this is something that needs to really be improved. Yeah, I don't know if
Yeah,
anyone
I think, yeah,
says.
anyone else have comments on it? I think that's very honestly stated, Christina. It's the facts, right?
Yeah, really. So I hope the new figure staging will be better appealing to all of us, of you. I mean, there is no way that we will not include molecular markers. There is just no way because
Mm.
that is the future, really. The question is, how do we incorporate it in a way that it's less intimidating? We have to think about that.
Yes, agree. Yeah. And some of the barriers in the systems that exist.
No, absolutely. Absolutely. But I mean, we can only aspire and do what we can do. At the end, it's not just the intention of the health professionals and health societies, but also of the governments, of the stakeholders,
Mhm.
resources in every country. So yeah.
It's a challenge, not even in Europe, but everywhere, right? Absolutely. There was some interesting things on surgery, which is obviously right in your wheelhouse, Christina. Minimally invasive is always of interest. I think people who are evolving and working more towards that in some parts of the world, but especially in Europe, I'm not quite sure how adapted is minimally invasive surgery.
Well, there is no difference really, is there, between you? I mean, it doesn't, minimal invasive surgery doesn't have to do really with a region, but minimal invasive surgery is the way to go everywhere in all cancers and situations where where open surgery doesn't need to be done. So all of us just do minimal invasive surgery is the first approach if possible. What was the concrete question about MIS, Mary?
It was just more about, like one of them was about the anatomy and updates in endometrial cancer, about surgery with borderline ovarian tumors. There wasn't really much that specific.
Okay, so endometrial cancers, I mean, we all do sentinels now. We don't do any more systematic lymphadenectomy. It was a very nice, where was I the other day? Where was I? I don't remember. Anyway, I don't remember, I was somewhere. And there was a very nice talk from David Chibula
Oh,
about the fact that sentinels, and I actually share this view, that even we stop doing systematic lymphadenectomies, we all do sentinels now. At some point, we'll all rely so much in endometrial cancer in molecular staging, in molecular
mm.
classification, that we won't even need the sentinel extra, to be honest. Which is good on one hand. On the other hand, that makes it an issue and challenges for the training.
Yes.
Because, I mean, I remember when I was trained, I used to do, I don't know, 10 systematic lymphadenectomies per week. So you learn. And now it's very, very difficult to teach it just because the indications are so much less. So this is great for our patients, of course. But on the other hand, it's the training opportunities are becoming less and less, and that is not something that is unique to Europe. But
Right. Yeah. And Nadia, thank you for including your comment here. Um, Being a researcher, former scientist, and now looking to accelerate that scientific collaboration. So I would be happy to have a conversation with you offline about this and talk about what are some of your goals and what might be ways we could work together. That would be great.
exactly, that is, for example, a cross collaboration across
Yes.
continents, with
Mhm.
Africa, with Canada. That's something like that is great. Yeah, absolutely.
Very much so.
And now, very quickly for borderline ovarian tumor. So I'm
Yeah.
very passionate about not doing MIS in advanced ovarian
Mm.
cancer if we have peritoneal disease, but for borderline tumors, really, we have proven in many studies the safety of the MIS approach, if possible. Yeah, so borderline tumors are absolutely not a contraindication for MIS unless it's a massive tumor, in which case you have to open up. But
Right.
otherwise, yeah, all the staging, resections, absolutely. So there was a question about that.
Right.
Endometriosis is not part of IGCS in terms of cancer, but still now we know that there is a higher interaction between endometriosis and cancer. There are many studies that have shown that it's a very tricky topic because it's just completely different patients to the cancer patients. Yeah, these are patients that want to preserve their fertility. They have a benign otherwise condition that is debilitating them. So we could actually have a whole society just for endometriosis.
Yeah. Absolutely. And I think these are, tough cases. And you're right. The incidence of cancer with endometriosis is always something that has, I guess, surprised me more than anything.
Yeah. It's not really yeah, it is. I mean, it's anything that mutates and can
Mhm.
go rogue in the human body, and that's what endometriosis
Yeah,
does. So
great. And then there's a little bit on pathology, again, a very evolving area. Digital pathology is becoming more and more, I think, discussed. Uh, Pathology staffing, I think that was interesting. I'm not quite sure what was meant by that, but I do know, you know, pathology is definitely an evolving area right now as, therapeutics and diagnosis continue to evolve.
oh, absolutely. And I mean, the pathologies are now integral part of any Gyn Society
Mhm.
guideline. So it's not anymore that we are just leaving them out. But yeah,
Right. And they're great partners. We have really enjoyed ISCHIP as part of IGCS in many ways. And I think the rare tumors is really going to bring us even closer together as organizations,
yeah.
recognizing the central review that we'll need.
No, absolutely. There is a comment from Joe
Oh,
that there is
great.
a good article of RCOG CPT. So it's the RCOG, it's the Royal College of Obstetrics and Gynecologists on endometrial
Awesome.
cancer. Yeah, that shows the correlation, how to consult patients. There is a very nice also paper in Lancet that shows a 4 times higher increase of the association. So it's a bit, yeah, there is a very clear association. It's just that where we place it, there are endometriosis societies. Yeah.
Yeah,
Which
definitely. Yeah. And thank you, Joe, for putting that in there. And then I know endometrial cancer staging has been controversial, a little bit of a moving target. I know FIGO has recently addressed things, and we were grateful for the opportunity to comment on some of their work. I don't know where this is landing now, Christina.
Well, I just said we are updating it, no? I just said it. So we are
Oh, was
now,
that endometrial? Yeah, I apologize. Yeah.
yeah, no, that was that. So we are now, so we have many more, in terms of diversity and inclusivity from working members of the committee of of the new FIGO endometrial cancer staging. So that especially we address low resource countries. So that's something
Hmm.
that we really more pathologists. If you remember in the 2023 FICO staging, there was only one pathologist from Spain. Now we have various pathologists from all over the world, so that exactly these issues with molecular stagings can be addressed better. And then before this will be released, it will be officially sent to all national, international societies for approval.
Great.
So it will be a very big, yeah. Listen, nobody can always get it right, I think, as we all know.
Oh,
And
yeah.
still we listened because there was a big drama when the 2023 was released. So we didn't want, yeah, we listened. Otherwise, it would be stupid really not to listen.
Yes.
And that is why we did it. And yeah, we have to see how the new figure will be. I hope by the end of 2027 it will be out.
Yes, and I think FIGO taking the opportunity to get input from other societies is really a big step forward. And so again, we're grateful, for that opportunity, definitely. And
Absolutely.
your regional representatives really did weigh in as you did. So that's great. And then these are just some miscellaneous ones. I hate the category miscellaneous, but these kind of didn't fall in anywhere else. So I don't know, Christina, if anything sticks
Yeah.
out to you.
Yeah, first of all, I don't know if anybody on the call wants to say anything.
Yeah, please, anyone. This is open conversation, so.
Yeah, absolutely. Um, so AI, this is now the new hot trend. Every conference, everything has an
Yeah,
AI session,
yeah.
which is excellent. I mean, we had a very nice AI session in where was it? In Cape Town, no? Where
Mhm. Oh, yeah, that was fun, remember? Yeah.
ChatGPT. I mean, it's not 100. I think to all of you who are younger, uh, do not 100% rely on the AI, on the ChatGPT knowledge, because currently what I've seen, I mean, I see it also in my kids, they don't read anymore. They just ask ChatGPT, they get an answer summarized and done. So
Yeah.
all this art of looking into literature, looking yourself, it's actually amazing that, what we used to do to go into PubMed to try to read, to try to reach a conclusion. Nobody does it anymore.
No.
So it's not
Yeah.
only that you are missing potential information because ChatGPT is never 100% right, but you're also missing the art of trying to look for the truth yourself. It's like
Hmm.
not a treasure hunt. There is no treasure hunt anymore. You just get the treasure. So that is a bit of a pity. And it's
Yeah.
the category where like we don't do lymphadenectomies anymore. So it's a completely new way of yeah, of thinking, of training. Trials and prevention. Yeah, trials and prevention. So many of the trials currently are focusing on prevention, especially in endometrial cancer with obesity, with all the GLP-1 antagonists. All these are now new, yeah, and many more new to come. So absolutely. What was the question about that, Mary?
It was just a reference to trials that are happening in the area of prevention. Yeah,
Yeah,
I think you
absolutely.
got it. Yeah.
Absolutely. I mean, in the past, we just used to do prevention just by doing screening. Now we really have prevention strategies like
Mm,
bariatric surgery, GLP-1 antagonist, vaccination. So really effective ways to, yeah, to prevent. So that is very
mhm.
important. Cancer and screening. Mm. There are screening studies, out of the box screening studies, especially for ovarian cancer, which is, as you know, my favorite topic. Uh, Outside of the box screening, so not just an ultrasound and CA125, but novel out of the box strategy of collecting a fluid from the fallopian tubes, from uterine lavage, in tampons,
Mm,
from the fallopian tubes in order to CP53 signatures. So there is a very big study that we did in Imperial, the clock study. It was very interesting, where we took loyalty cards from medication for drugstores, and we saw that patients with future diagnosis of ovarian cancer have started taking more painkillers and antacids 6 months prior to their diagnosis. Mm. So we are now doing not the conventional screening,
no, yeah,
come do an ultrasound, nothing, thank you. But we are trying to really have innovative ways to try to understand HPV
right.
now, cervical cancer, that even the patients do just an HPV test and not really rely on going to a doctor to have a cytology. So there are many new ways.
Yeah, I think people are always searching, right, for something in this space.
Oh yes, absolutely,
Mhm.
absolutely.
Anything on the final two?
Yeah, autoimmune disease and pregnancy complications. Is this cancer?
It did
No.
not say. Mm-mm.
Uh, so we do a lot of cancer-related pregnancy in cancer, cancer in pregnancy, yeah. But autoimmune disease and pregnancy is a huge. I mean, it's very funny. When I started my training, this was my topic of expertise. That's what I wanted to do, and I had actually
Mhm.
a clinic
Yeah.
of autoimmune disease and pregnancy. Has nothing to do with cancer, but it's always nice to hear. Neoadjuvant chemo are zero disease and immunotherapy for ovarian cancer, a huge topic. We can keep talking. The only thing I can tell you is that tomorrow I have a meeting with the statistician of the trust and Sven Manner to try to finalize the manuscript. What we have seen, and these are data that Sven Manner has presented to you in ASCO, is that patients with a pleural fusion
Hmm.
will do worse if we operate them up front. So these are the patients that should go towards neoadjuvant chemotherapy. And we are trying now in the final manuscript to differentiate the patients, to do a categorization of patients of 3, 4 groups, where we can say this group should go up front, this group should go whatever, both sides fine, this group should go a neoadjuvant chemo.
Mm.
So there is a lot to go. In terms of immunotherapy for IO, there was a gyneco study with pembrolizumab neoadjuvant. Thank you, Anna. Yeah,
Mhm.
I hope we can really do that. If I can disclose you already, I think it will be 3 groups. The first group will be the stage 3 patients, operable stage 3 disease, operate up front. Then there will be the group with pleural effusion. So no matter if stage 4A or 4B with pleural effusion, they should go neoadjuvant. And then
Mhm.
the third group, the group of stage 4 disease without pleural effusion, but operable stage 4, let's say a trocamet, a splenic disease, a inguinal lymph node, that can go both ways. Yeah, you consent for both. And depending on how the tumor dissemination patterns are, how the symptoms of the patient are, to go both ways. I mean, this is something that I have now started doing also in my practice.
This feels like a little hot off the press, is it?
Yeah, it is. I mean, Sven already mentioned it on the in ASCO, but yeah. Mhm.
That's amazing. Thank you for sharing that. Well, this has been super fun. Is there anything else anyone wants to ask? You can certainly put it in the chat or reach out to us. I wonder if we shouldn't do a picture. It didn't happen unless we do a picture in social media, right? So if anyone wants to put their camera on, if not, that's okay as well. But I would like to thank Christina for her preparation and work in doing this for us. Thank you. It's always great to work with you, and I learn so much from you every time we do things like this. So thanks a lot, Christina.
You from all of you. Thank you. And
Yeah,
thank you,
thank you.
everybody. Does anybody have any questions or anything that they want to share?